At the last session of day one, and we can't thank you enough for attending. So much good content, once again focusing on those first few hours when a sick patient arrives. What are the things we need to do, whether they're medical, whether they're trauma, exsanguinating, cardiac arrest, ACS. And to continue along that theme, almost every one of you raised your hand when I asked about the use of non-invasive ventilation, but there are certainly pearls and pitfalls to its use. So Haney's going to begin this last section of day one talking about using non-invasive ventilation like a pro.
All right, you've had a lot of science today, a lot of medicine today. I think at this time, we probably should take a step back and let me just tell you a story. Okay, you all good with that? This is a true story about my first day as a critical care fellow. As I told you, I did a EMI residency in Brooklyn, New York, and I got to admit to you, now that I'm looking backwards, I was a little cocky on my first day of fellowship. I thought I had seen it all, I thought I had done it all, and this fellowship would kind of pass by and, I'd learn a thing or two here or there. So I show up on my first day of fellowship, dressed real nice, ties all straight, and we finished rounds, and I got my first page. Oh, for those of you that don't, there was this little thing we carried on our waist that beeped. That's for the millennials who don't know what that is. So I took the page and I called back. And it was the ED calling because they had a 7-year-old female who was coming in with a COPD exacerbation, and she looked terrible. And they put her on non-invasive ventilation. They put her on Bipap. And so I was used to working at the county hospital where you try to get a little snarky on the phone. And believe me, I'm a little embarrassed about saying this to you because I'm an EM physician too, and all you are as well. So please, this was the past me. This is the new me. Oh yeah, so PCO2 is high. Any past medical history? Yeah, does she smoke? And every time I asked a question, I wasn't getting anything back. And I was just, so finally, after 4 or 5 questions, I was like, hello? They had already hung up a long time ago. You see, where I trained, it was very different than the county. They weren't asking for permission to come to the ICU. They were telling you, oh, by the way, that patient's on their way up, just so you know that's your next patient. It's all right, though. A couple minutes went by, and that patient rolled into the ICU. And I looked at the patient from across the ICU. I said, crap, that patient really does look kind of sick. And so my nurse and I went into the bed, went to the patient's room that they were going to be in, and the respiratory therapist came in. And we looked at the patient, and the respiratory therapist said, this patient doesn't look very good. I said, thank you. I know that. I'm nervous enough. And so they were asking me what I wanted to do, and I got to tell you, I really didn't have a clue what to do. Because it was 10/5 on the non-invasive, so I just acted like I was examining the patient while I was nervously trying to think, what the heck am I going to do? So finally, time was running out, and the respiratory therapist said to me, Doc, what do you want to do for this patient? So I took a deep breath. I looked at the respiratory therapist. I think I even whipped off my glasses, and I said, what do you want to do with this patient? But this respiratory therapist, she was smart, she was wise. It was her first day of work too. And she looked back at me and she said, what would you like to do, doctor? That was a little bit more back and forth about what do you want to do, what do you want to do, what do you want to do. Finally I said, all right, I'll make a decision here. Patient's on 10/5, let's take the patient to 15/10. So we put the patient on 15/10, and the patient didn't get better. Everything stayed the same. I said, okay, we'll go to 20/15 for this patient, and nothing really changed. And then it wasn't until we got to 25/20 that things started to happen. The patient started to get bradycardic and hypotensive. First day of fellowship coding my very first patient. It's going to be a long 2 years, But I'll tell you what, I learned a lot that day. Bring an extra shirt because you're going to sweat through it. But I also learned an approach to non-invasive ventilation because that was a really traumatizing experience for me. I really didn't know anything about non-invasive ventilation. And so what ensued after that was my search for a very simple algorithm that we can use for our patients, approaching them for non-invasive ventilation. Because I'll tell you, I believe everything in critical care should be really, really simple. When that patient is sick in front of you, then is not the time to go through many differentials and scratch your chin and come up with formulas. You need rapid approaches to the sickest patients, and hopefully this approach will ring true as it does to you as it does for me. So let's go through it. All of you in this room are masters at the airway and are exceptionally good at managing patients with respiratory difficulties. Every once in a while, though, you're going to come across a patient who you're going to tube them, but you're not exactly sure what's going on with them. And the approach I want to introduce you today hopefully will help you to clarify that and pick the appropriate therapies for that patient. And this is simply called the rule of twos. Now I'm going to tell you, whenever I ask you a question, all you have to say is two. You don't even have to have heard the question. I'm just to say two back at me and you're going to be right. Because that's all the rule of twos is all about. Let me show you what I mean. So how many types of respiratory failure are there? Exactly right. There are two types of respiratory failure. You guys are great. There's a failure of oxygenation, which is known as a type 1 or hypoxemic respiratory failure, or there is a type 2 respiratory failure or hypercarbic failure to ventilate. You with me so far? Okay. If you have a two, thanks one guy. All right. If you have trouble with hypoxia, how many different ways can you treat that person? Two ways, right? You can crank up the FiO2, but you can also increase the mean airway pressure for that person. So someone with a really dense pneumonia or CHF, they're collapsing down their alveoli. You need to recruit up those alveoli, and increasing your mean airway pressure is the way of doing it. If you have somebody who has a hypercarbic respiratory failure or retention of CO2, how many different ways can you treat that person? Two. We can increase the respiratory rate, or we can increase the tidal volume, increase their minute ventilation. Now, certainly you're going to come across instances where both can be overlapping. Take the person who has a pneumonia, right? A type 1 problem, and they've been struggling with it at home, haven't come to ED, and now they're starting to tire out and starting to retain CO2. Certainly you're going to get overlap of two, but I encourage you, whenever you have a person who's in respiratory failure, to take a good look at them, scratch your chin, and try to figure out what the primary problem is. Because if you don't know what the primary problem is, it's going to be very hard to reverse their overall process. Now look, 3:30 in the afternoon, I'm not going to bore you with a boring physiology lecture. But knowing this is really the building blocks to the rest of the lecture, and it's very, very simple. Now, everyone always wants to talk about ventilators and invasive positive pressure ventilation, and I'll just go into that just a little teensy-weensy bit. But what I want to focus on is non-invasive ventilation, because the principles are actually the same. So if you understand non-invasive, invasive should be relatively similar. So how many different types of non-invasive ventilation are there? Two. You can either do continuous positive airway pressure or bilevel positive airway pressure. So here's a case. And if you know me, none of my cases are ever tricky. I'm not trying to catch anyone in the audience. So if it's easy, just shout out the answer. This is a 65-year-old person who has a history of CHF, who comes in with respiratory distress, RALs everywhere, and bilateral pleural edema. Now, I see some younger folks in the audience that are still not really sure what's going on when they look at this. So don't worry, I got you guys covered. There you go. There's those B lines. B lines in a heart that's not working so well. So this person has CHF exacerbation, exactly right. And this is a type 1 respiratory failure. There is stuff in the alveoli. The person can't get oxygen across the capillaries, right? This is a type 1 respiratory failure. Okay? For this person, they need continuous positive airway pressure, Cpap. Cpap is helpful for hypoxemic respiratory failure for a variety of reasons. The first thing is it helps you to unload the preload to the LV. That positive intrathoracic pressure that you're doing when you're cranking up that Cpap is going to decrease venous return, helping out that LV to get back down on their Starling curve and push blood forward. It also helps to pop open those alveoli that have collapsed and keep them open. Because what happens, you take a breath in, you open up the alveoli, they collapse right back down again. But when you provide continuous positive airway pressure, or EPAP, or PEEP, whatever you want to call it, it's all the same. You keep those alveoli open. So that will decrease your work of breathing, because that's when the most energy is expended, when you're opening up those alveoli. And then finally, it helps you with your functional residual capacity, your FRC. And a really simple way of thinking about FRC is it's just that little part of your gas tank that holds that gasoline when that light comes on and says, you know, you got a couple more miles. That's what FRC is. It gives you your apnea time. It gives you your reserve. So Cpap helps with patients who have type 1 respiratory failure. It helps them with that FRC. So here's a neat little video from YouTube that I want to show you. This is a pig lung, And this lung is completely collapsed down. And look what happens when you don't use any PEEP, when you use zero PEEP, or ZEEP, as they like to say in the business, okay? So look at what happens with ZEEP. You put a breath of air in, it collapses down right back to normal again. And you push air in, it collapses back down to normal. The problem with this is that there's forces that are exerted along the bronchial tree and the lung that cause stretch. So there's forces that cause injury when the lung is blowing up, and also when these lungs collapse back down, there's injury to that as well. Nothing we're going to see in the ED, but believe me, upstairs in the ICU, these are things that lead to problems over the long term. So if you can reduce that and go to something like this with 15 of PEEP, look what happens. A breath goes in, but at the end of the breath, that lung stays open. The next breath goes in, it still stays open. Next breath in, it still stays open. You're recruiting and splinting all these alveoli, and you get better oxygenation for your patients. So sure, you can crank up the FiO2, but if you can't recruit open those alveoli and keep them open, you're going to go right back to the basics again. So that's CPAP. Now there's two ways you can do CPAP. You can do it with a nasal cannula, or you can do it with that tight-fitting mask. Now when I say nasal cannula, I don't mean like the 15 liters that like every TV patient has on TV. I'm talking about high-flow humidified nasal cannula. How many of you folks have that in your institutions? Yeah, more and more people are doing this. This is the thing for a while that's been in the ICU, and it's starting to migrate downstairs now because it's a really simple, non-invasive tool that you can use for your patients. Look at all the things you can titrate. You can titrate the FiO2, so it works perfectly for type 1 respiratory failures. You can titrate the temperature of the air because it's a lot of air that's flowing in, so you can make it humidified to a certain temperature to patient comfort. But most importantly, you can titrate the liters per minute that you administer to your patients, and the higher the liters per minute, the more of that EPAP or CPAP that you're providing to your patients. So higher flows get you more splinting. Some of these devices go up to 80 liters per minute, quite high. So far, no one's heads have exploded, but it is quite a bit of flow, but you can generate a lot of PEEP for these people. Now, what PEEP do you get? No one really knows. It's anywhere between 0 and 8 centimeters of water, based on the studies you read, and based on the patient habitus, how much soft tissue they have in their oral pharynx. But I call this diet CPAP. If you're looking at somebody and you're like, yeah, they should get some tight-fitting masks, but they're not quite there yet, try some of this. This will help some of those patients out. Not all, but it's just kind of in between using completely nothing and using the tight-fitting mask. And then, of course, we know CPAP, right, with the traditional mask that EMS brings in. And that's a tight-fitting mask that patients come in with. And this generates a lot of pressure in the airways. And it's a great device. The problem is, I'll just go back for 1 second. The problem with this is, and we don't see it in the ED, but over days, patients get septal necrosis up here. And it's a big morbidity for patients. Patients have to get plastic surgery. And what they've realized is that maybe we need to go on to other sort of interfaces for patients who are getting this non-invasive ventilation. So this is another device they've come up with that distributes the force around the face so there's not that one point of pressure causing septal necrosis. So this is an alternative to using that tight-fitting mask or that nasal CPAP that you sometimes see. Now there's even something newer than that that's been on the market in Europe for a while, but has now come to the States, and that's this thing. This is the thing. The Cpap Hood. No pressure on any point, just on the neck, and this creates a positive pressure environment so their nose and their oral pharynx can get oxygen. I think this thing is fantastic because, again, it doesn't provide pressure on the septum. Patients tolerate it very well. They can take breaks and eat some food every once in a while, talk to their families. But my personal favorite for why I like this is that anytime I have a patient that's asking a lot of questions, I can just zip it back up. Mr. Smith, it's time for some therapy again. Exit stage left. So how do you start off your CPAP? How do you start your initial settings? You can start at 5. Why 5? That's just the number that people do. If you want to be snarky and start at 4, have at it. But start somewhere. But that patient that's sick, you're not leaving their bedside. You're going to sit by them every 10 to 15 minutes and increase by 3 to 5 centimeters of water. Now, there has to be a maximum. The maximum I recommend is 20 because patients' lower esophageal sphincters vary between 23 and 25. I don't want to insufflate a stomach for someone who's in respiratory distress. So I make my 20, my hard cutoff, and if that patient still doesn't look good, it's time to intubate. I didn't fail, I was aggressive, but that patient's disease is not going to get better. And the truth is, if you're at 20 and they're not getting better, they're probably not going to get better at higher levels. All you're going to do is increase your aspiration risk. So I make my limit at 20 centimeters of water. Case number 2, this is the patient that came up to my ICU. Again, 70 years old, COPD, hyperinflated diaphragms, no tricks up my sleeve. This is a COPD exacerbation. This person needs Bipap, or bilevel ventilation. Just so you know, Bipap is actually a trade name. And we say it all the time, get the Bipap machine, but it's technically like saying Tylenol. Okay, I don't know, CME conference, oops. But Bipap is a trade name. So if you really want to be academic, say Bipap or say bilevel ventilation, but I don't think anyone's going to call you out about saying Bipap. Now, the secret with Bipap is that it has 2 pressures, bilevel, 2 pressures. It has an inspiratory positive airway pressure and an expiratory positive airway pressure. And the best way I can describe this is going to the gym. Anyone go to the gym and do some serious weights? All right. Yeah, I can tell. So you would be at the gym, and then you would see me, and like, this guy's not working out, so he can help me out. And you'd call me over, and you'd say, hey, can I get a spot? And what's a spot? A spot is when someone is doing a repetition, that's what they say in the gym business, the rep, right? I don't know. I just read this and read on Wikipedia. So when you're doing a rep, what happens is the patient, initiates that rep. And during that rep, you provide some support for them. That's what the IPAP is. You're providing a support when they initiate that breath. And when it's time to release that breath, you're providing support on the way down. So IPAP is when that person initiates the breath, you provide some support in the background, and then when that's released, you provide some support on the way down. That's what Bipap is. And so that's why it's important you know what you're titrating. Because the delta between the two is what's going to determine what's called the pressure support, essentially the amount of tidal volume that you're giving your patient. So it's good for patients who are having a hypercarbic respiratory failure because the bigger the delta, the bigger the tidal volume you're going to give that person, the more CO2 clearance you have. But if you have that patient who also has a hypoxic component, again, take that pneumonia example, that person that's tiring out, you can provide a little bit of support, some EPAP at the end, to provide some support for that lack of oxygenation. So if the person is the COPD patient, all they need is a delta. They don't need any EPAP. They could be 10 over 0, right? 10 of IPAP, 0 of EPAP. But if they have some hypoxic component, you want to titrate the EPAP. And that's why it's so important to understand this stuff from the building block perspective, because every patient that comes in is going to have a different disease. It's not just about putting them on Bipap. It's knowing how to titrate each individual variable. So how do you set it? Again, if the person's a pure COPD exacerbation, you can start them on 5 to 10 as their IPAP, and determining how much CO2 clearance they need, you can set your EPAP. Now, I'm a believer that if the person's coming in has no oxygenation issues, put their EPAP at 0. They call it, like I said, ZEEP. Every once in a while, I'll find somebody who has a real problem with this. It's like, you have to give them PEEP. You don't have to give them PEEP. But they say, you have to give them PEEP. And I say, you don't have to give them PEEP. They say, you have to give the patient PEEP. So I put them on EPAP of 1. All right? You asked for EPAP, I gave you EPAP. The point is if they have no trouble with oxygenation, there's no need to give them the EPAP. Intubated patients are a little bit different. But in a non-invasive patient, you don't have to give them EPAP. Some people will tell you otherwise. Again, I'll leave that to you to decide. But what's most important here is the delta between the two if you want to ventilate their CO2. And again, you can set a rate on some of these machines, but most of these patients are already going to be tachypnic on their own. You don't have to set their rates higher than their intrinsic. They're already breathing fast on their own. Now, why did my patient code? As a reminder, I stupidly did 10 over 5, 15 over 10, 20 over 15, and then 25 over 20. Why did that patient code? Same delta. But what did I succeed in doing? Increasing intrathoracic pressure, decreasing venous return, and that's why that lady coded. Now, patients may come in, and I'm sure you've all had this experience. Patients come in, they look really sick, and you want to put the non-invasive, whether that's CPAP or Bipap on them. And they say, I don't want that, tube me. They're like, are you crazy? You want to be tubed rather than non-invasive? They say, absolutely. I do not want that. I feel like I'm suffocating. I feel like I'm drowning. And what do we say? Ma'am, you're sick. You're confused. Trust me, I'm a doctor. Try the mask. And they say, I don't want the mask. And you're like, try the mask. And they push you away. They say, I don't want the mask. You're like, just try the mask. Get some Haldol out of it. It happens because patients have had bad experiences with it. So I want to give you an alternative to just shoving the mask on their face, and it's trying this method. When they come in, give the patient the mask and empower them and say, I'm going to let you apply this mask when you feel ready. So I give them the mask, and I put the settings really low. I'll put it on 3 or 4 centimeters of water. I say, when you're ready, put it on. And sometimes I'll coach them. I'm like, try now. But I don't put the straps on. And I want them to feel empowered and liberated so that they start to get comfortable with the mask. They start to sync with the machine. And then over time, I start increasing the settings, and then I sneak the elastic bands around their head. And I gotta tell you, once I started doing this, most patients are okay with this. I don't have to give them fentanyl or Haldol or any sort of sedatives. But you gotta talk into them. Some of them have had some really terrible experiences. They feel like they're drowning. When you talk to them in the ICU after they get better, said, I felt like I was underwater. I thought I was gonna die. That's why I wanted you to tube me. Now, just a quick review. Patients that we don't wanna do non-invasive on are patients who are completely altered. Now, it's kind of like the art of medicine, what you call alteration. You've all had those people come in who are a little confused, but with a little bit of non-invasive, maybe they'll turn around. That's fine, because hopefully you're standing by their bedside ready to help them. But the person who's truly altered can't clear the secretions. They can't clear their aspirations when they vomit. They can't tell you, doc, enough is enough. So if you're not staying by the bedside, be very careful with the person who's truly altered. Patients who are actively vomiting. I still see this sometimes. People waiting for them to finish vomiting say, hey, their stomach is empty, now we can do the non-invasive. It sounds crazy, but these are some smart clinicians, and they have some good reasons. Just be very cautious. The person is actively vomiting. Patients with secretions that the patient can't handle their own, and anyone that has a history of airway obstruction, tongue cancer, laryngeal cancer, those people you want to get to intubating right away. Other people you want to intubate immediately, patients with hemodynamic instability. Many times I'll see patients who are on a little bit of pressure, and they're also on non-invasive. Realize that person who's having non-invasive ventilation and is hemodynamically unstable, they're exerting a lot of cardiac output just to go to their intercostal muscles in their diaphragm with that metabolic acidosis we talked about. So they're expending a tremendous amount of cardiac output just going to those muscles. That is a person who I want to intubate and take away their work of breathing for a little bit of time. Sedate them deeply, give them good analgesia, and let them take a break so that cardiac output can go to the other organs that's afflicting them. Higher illness scores is the same reason. Patients with ARDS. So when you meet somebody in the ED who has ARDS, no matter how bad their x-ray is or how good their x-ray is and it looks patchy and infiltrative, it's going to get a lot worse before they get better. So there is some evidence that for patients with mild ARDS, you can try non-invasive. But I encourage you, if that person's sort of scrapping by and their chest x-ray looks really fluffy, they're going to get a whole lot worse in the next couple days. You might as well intubate them now when they have a little bit of physiologic reserve, and you can do that hemodynamically stable intubation than the person who's crashing hypoxic, and then they're going to go into cardiac arrest. So have a lower threshold to intubate those patients. And then finally, the last thing I'll say about when to determine intubation for these patients, and this is a little bit of a gray zone thing, but whenever you meet a patient who's going to be on non-invasive ventilation, I try to give them a time that I'm going to give them on the therapy. In other words, I had a patient last night who was sick. I told that person, you're going to have 45 minutes of non-invasive ventilation. 45 because that's just what felt right to me. But I know in that 45 minutes, I am going to go maximal with my settings, with my diuretics, with my settings. I'm going to crank things up. And if at the end of that 45 minutes, that person's still not doing better, then it's time to tube them. But I think it's important that for every patient that you see, you set some time limit to say, if I maximize everything, enough is enough. It's time to intubate them. Because I still would much rather intubate somebody who has a little bit of reserve than the person who's somnolent, who's hypoxic, who's starting to drift down. That's the crash airway, and that's one that I do not want to do because that person almost certainly will do worse. So every patient sort of has their own little expiration date, if you will. Well, that's a bad choice of words. Terrible choice of words, in fact. Every patient has a time till they tucker out, and try to get ahead of that time. So that's the rule of twos. Very simply, there's two types of respiratory failure. A failure of oxygenation And the only two things you can do for that is crank up the FiO2 or increase your mean airway pressure, or failure of ventilation. You want to increase the minute ventilation by increasing the respiratory rate and or the tidal volume. Non-invasive ventilation, two interfaces, continuous positive airway pressure, which is for the type 1 respiratory failure, or Bipap, which is for type 2 respiratory failures. Now, one quick word on invasive positive pressure ventilation, because although it's a talk into itself, it's really not that much different. The principles that I just told you are the same for someone who's intubated. So if you look at a ventilator, and this is the ventilators that we have, but most of them are laid out the same. Look at how everything is lined up. On one side of this line, you have your FiO2 and your PEEP, or your end expiratory positive airway pressure, and on the other side, you have your respiratory rate and your tidal volume. So it's set up the same way. When you get that patient who you intubate and you're looking to see what can I do to make them better, these are the variables you're going to adjust. If they're hypoxic, increase their PEEP first. And if they're having respiratory acidosis, the stuff you do every day, crank up the ventilator, crank up the tidal volume. Try not to exceed 8 cc's per kg. That's my last talk for today. I'll be back tomorrow to talk to you about sepsis. Again, please don't hesitate to reach out to me if you have any questions at all. It's been a great pleasure talking to you today. Thank you.
Thanks so much, Haney. And while we bring up Dr. Cantor's talk,